All right, so my name is Nicholas Pokrayats. It's okay, it's a hard name to pronounce. And thank you all for having me. Today I'm going to talk about a program that I lead at my institution, which I started under the mentorship of our Vice Chair of Education, Dr. Mike Gisandi. And my hope for this talk is that it will provide some useful insights for those potentially interested in starting a similar program at your own institution. And I have no disclosures to report. And so this probably looks very familiar to at least some of you. The CanMeds framework really embodies the push towards competency-based medical education. But what does that really mean for practicing physicians, particularly when it comes to the maintenance and development of skill mastery for bedside procedures? We attend courses and workshops, but we don't really routinely undergo performance assessments that are necessary in a model that stresses the importance of outcomes. And this is really despite some evidence, including a lot of work that I've done at our institution, that demonstrates that academic faculty in particular may have some suboptimal and variable performance of bedside procedures when they're objectively assessed. And here's some data from our institution of some volunteer emergency medicine faculty put through a simulator for the procedures that are listed. And you can see it's pretty varied performance. The black line at the top is our passing standard for these exercises. And you can see a lot of people did not meet the passing standard on their initial evaluation. But this makes sense, right? Because skill decay is a really well-recognized problem. And that is, for some procedures, we simply don't get enough opportunities to practice in the clinical environment, either because of the rarity of the procedure or because in an academic center, trainees primarily perform most of these procedures. And as a result, our performance declines with time. And since I'm going to be talking about simulation-based mastery learning, which is what we use for our initiative, I think it's worth familiarizing this group with it in case you're not familiar. And so simulation-based mastery learning is really a rigorous model of competency-based education that has a substantial amount of evidence demonstrating improved patient outcomes when implemented, at least during residency training. And so there are several necessary components of simulation-based mastery learning. I'll highlight a few. One is baseline assessment of a target skill, discrete learning objectives, attentive learner engagement throughout the exercise, a defined minimum passing standard, and testing during the educational process to both direct learning, provide feedback, as well as evaluate achievement of the passing standard. And this is really time variable, so it's continued practice until that standard is achieved. And so what you get, this is a very famous graph, what you get is this target learner group that normally would undergo sort of a bell-shaped distribution of their outcome into a more uniform high level of performance. And so our initiative was to try to fill this gap of sort of skill training in that's more objective and more aligned with the competency-based model. And by doing so, to implement a simulation-based mastery learning program to develop and maintain bedside procedure skills for clinical faculty. And we chose simulation-based mastery learning, again, because of how good the evidence is for residency training. And so here's our process. We would start with a procedure, and the way we would select a procedure was either through a needs assessment of our group or trying to align our procedures with our residency curriculum, kind of with the barrier of what equipment we had available. We would then move on to checklist development, and that would occur usually through a literature review. We would identify existing assessment tools and adapt them towards our purpose. And if we didn't really find an assessment tool that we thought was valuable for our faculty body, we would undergo a consensus-based process for development using something like a Delphi process. We would establish a passing standard for those assessment tools. And then if I wasn't the one entirely doing all of these sessions, we would have some peer facilitator training, some pilot testing or assessments, some calibration, and then work out all the logistics, things like signups, booking room space, all of that stuff. And the end result was really this simulation-based mastery learning for teaching faculty or for continuing professional development. And another thing we really paid close attention to during this process is psychological safety. Understandably, having a peer assess your performance is uncomfortable, particularly for those that have been in practice a long period of time. There's a lot of unique challenges with having this model in teaching other faculty. And so to do that, we took a lot of steps to make sure that participants felt like they were in a safe learning environment. Things like having our signups be confidential. We performed assessments and feedback in a private room. These were all one-on-one sessions with a single participant and single instructor. And we were really attentive with the language we used in the room to try to avoid things like perception of judgment. And since we started this initiative, which was back in March of 2020, which we started right after the COVID-19 pandemic hit, we started with personal protective equipment use, actually. We've undergone, or we have done several procedures using this model, with the latest one being actually starting next week on fiber optic intubation, of which we have, I think, already like 35 faculty signed up for. And widely, this has been a very positive experience for our faculty. They very much appreciated having this individualized time to go over their technique and really be coached through to kind of a standard that we're setting for our department. Now, certainly this has not been without limitations. Simulation-based mastery learning and our initiative has been very time intensive. And so you can see, if you remember kind of or if you notice the spacing of our timeline, it takes a lot of time to go from development to implementation of these procedures, sessions, as well as all the time devoted to one-on-one teaching. The engagement of our faculty has been variable. And I think that's probably related to a perception of need for some procedures as opposed to others. We've run into some equipment availability issues, particularly for select procedures that may be a little bit more specialized. And there are generally, kind of after going through several iterations of this, a lack of assessment tools really specifically designed for this purpose for continuing professional development. And then the last one, which I think is probably the biggest, is, does this model improve outcomes in a continuing professional development system? We know it does for residency. We just don't have the evidence there in terms of use in faculty. And along those same lines, kind of what we're planning on doing next is evaluating for those changes, potential changes in patient-centered outcomes. We're going to be exploring some thoughts and attitudes of our participants and maybe some barriers that they're thinking or facing of engagement, as well as trying to develop a more robust set of assessment tools for a lot of the critical procedures we have, aimed specifically towards a population of high or advanced learners, faculty learners. And so with that, I will take questions.
Thanks very much, Nicholas, for showcasing that work. It's very interesting. Again, just for the interest of time, we'll take questions in the chat as we continue with the program. Nicholas, I assume you'll be here for the next 10 minutes or so. So I'm sure I'm speaking on his behalf that he'd be more than willing to answer your questions and garner your comments.